Thank you for taking a look at this bite-size ID video on antibiotic toxicities. This video, we're specifically going to focus on hepatic, gastrointestinal, and renal-based toxicities. My name is Nathan Everson. I'm a clinical pharmacy specialist here at Curling Clinic in Infectious Diseases. So starting off, we're going to look at hepatic and gastrointestinal toxicities, and so there's a bit of overlap between them. When we think about mechanism of injury, particularly for hepatic injury, we look at either direct toxicity or idiosyncratic. Our direct toxicities are a little bit more common, dose-related, predictable, more rapid onset, whereas the idiosyncratic toxicities can be more rare, not that dose-related, and a bit more unpredictable in terms of onset and overall presentation. When we look at some of our agents, we see either a hepatocellular, cholestatic, or mixed presentation. When we look at our hepatocellular, which is characterized by more of an ALT elevation, we see minocycline, nitrofurantoin, isoniazid, pyrazidamide, and rifampin as being kind of our major agents there. Nitrofurantoin isn't that associated with it because mostly we're using pretty short courses. In terms of isoniazid, pyrazidamide, and rifampin, very common medications in treatment of mycobacterial infections with long courses for more opportunity to cause hepatic injury. In terms of cholestatic presentation, with a little bit more of an ALP elevation, we see one of our #1 causes of idiosyncratic DILI being amoxiclav, and that's probably due to the frequency of amoxicillin clavulanic acid's use in the ambulatory setting. But other penicillins have some association, cephalosporins and erythromycin have all had some association with this presentation. Not always reproducible, sometimes stopping the medication, giving a washout and retrying, and patients do much better with a repeat. So rechallenges are possible in some of these situations. And then mixed picture we see with our sulfonamides that can have a little bit of a different approach depending on what's happening. For management of our hepatic toxicities, we see early recognition and drug discontinuation as one of our cornerstones. In some situations, we can do some hepatic dose adjustment, though most medications don't really have that, and making sure we're doing serial LFT monitoring to watch for any sort of increases or changes. In some situations, we can also use bile acid sequestrants if patients are having significant pruritus. Biliary sludging is another side effect we can see, and most frequently we see this with ceftriaxone. So ceftriaxone can displace bilirubin from serum albumin, and then we can have precipitation of cholesterol crystals leading to biliary colic, acute cholangitis, or even acute pancreatitis. We usually see this with younger patients in really high doses and prolonged durations, usually a combination of those three things, though can see it when those aren't present. When we look at monitoring, we usually see an increase in bili, though not always, increased AST, ALT, though sometimes it has more of a mixed picture. We can't see jaundice in some patients, particularly our younger patients. So it is something we can see with ceftriaxone, and seeing as that's a really common intravenous medication, something we should all be aware of for monitoring. And now we'll move into drug-induced pancreatitis. So, pancreatitis, of course, patients presenting with acute persistent severe epigastric pain, having elevated lipase and amylase, and then seeing pancreas enlargement on imaging. We see lots of different agents associated with this, and this is often difficult to associate some agents specifically with pancreatitis. Though when we look at our class 1A, which are going to be our agents probably have the most evidence, we see dapsone, isoniazid, metronidazole, sulfamethoxazole, and tetracycline as being some of the more causative agents. Tigecycline is also an agent that I personally have seen multiple times cause pancreatitis, though we use it much less frequently than we used to. Erythromycin has some association with pancreatitis. And then as we kind of move down into our agents, we're a little bit less association. We see minocycline. So if you notice, we've got tetracycline, tigecycline, minocycline all here. So the tetracycline class and the tetracycline derivatives definitely have some potential for pancreatitis. We also see erythromycin and chlorothromycin on here. So our macrolides have that potential. So though azithro is generally considered to be pretty safe and not super associated with pancreatitis. And then kind of our ones that may have some cause, it's hard to really elucidate, would be some of our penicillins, famciclovir, rifampin. Again, nitro, like in a lot of these other cases, we're not using it that for long courses, so rarely do we see some of these side effects. Now we're going to move on to renal toxicities, which are some of our most common toxicities that we deal with, both inpatient and outpatient. So, of course, doing renal function assessment, we've got our risk, injury, and failure definitions. We specifically have the rifle criteria up here, but there's multiple different classifications of renal injury, though the urine output is pretty consistent for most cases. And then when we look at our types of toxicity, we see acute tubular necrosis, acute interstitial nephritis, and then our crystal neuropathy. For our ATN, our acute tubular necrosis, that's our direct injury, and often can be dose dependent. Acute interstitial nephritis tends to be more of an allergic type response, so not dose dependent. And then our crystal neuropathy can be dose dependent. It may have a lot to do with the volume status of the patient as well. So for ATN, some of our classic agents that can cause ATM will be potentially aminoglycosides, amphotericin, polymyxins, and vancomycin. All have the association with some sort of acute tubular necrosis. For acute interstitial nephritis, I'd say our most common agents here are going to be beta-lactams, and often this is more ampicillin, penicillin, as well as our methicillin-resistant penicillins like nafcillin or oxacillin can all cause interstitial nephritis. Fluoroquinolones have association as well as sulfonamides. Vancomycin has association with both ATN as well as AIN, though I would say most commonly ATN is what we're going to experience with vancomycin, and usually after someone has gotten some significantly high troughs. Characteristics of our AIN presentation, pyuria, hematuria, proteinuria. We can also see eosinophiliuria, and then the kind of this constellation that happens with some AIN cases where we have a rash, fever, and arthralgia is kind of combination presenting together. It's kind of allergic type picture that we can see with AIN. And then our crystal nephropathy is when our agents precipitate out of solution within the kidneys and cause direct damage. And of here, acyclovir is by far the most common agent to cause this. It's associated with high doses. So when we've got patients on, we're treating for either high dose acyclovir for CNS type infections on the inpatient side, but also can see with valacyclovir when we're treating for shingles and some of our other diseases where we're using relatively high doses. It's important that patients have really good fluid intake, and if we're doing this inpatient having really good maintenance fluids that are keeping our veins nice and plump to avoid this kind of precipitation out and damage. Ciprofloxacin and sulfonamides also have an association here, volume depletion being one of our main risk factors, so keeping patients well hydrated with these medications is really important. Often we get questions about, what agent is causing the nephrotoxicity and how do we determine this? We see situations where patients are started on vancomycin and then changed to a penicillin, and is it ATN from the vanco? Is it AIN from the penicillin? And it can be very difficult sometimes to determine that because even though they have characteristics, patients of course don't necessarily follow the characteristics in every situation. Generally, a little bit longer course for ATN, though that really depends on like the dose situation. Interstitial nephritis can either take a long time to develop, or if it's a repeat exposure, it can happen very quickly. The clinical features of having rash, fever, and arthralgias is very associated with interstitial nephritis, so it definitely doesn't present in every case. We can see eosinophilia both peripherally as well as see eosinophils in the urine with interstitial nephritis, though again, it's only 35 to 60%, so we have lots of cases where that doesn't happen. In terms of treatment, in general, we're going to want to remove the agent whenever possible. Steroids may have a little bit of benefit in an interstitial nephritis situation, so that may be something to consider, but generally removing the agent and giving supportive care is what we're the most worried about. In terms of prevention, making sure we're doing renal dose adjustments for patients, particularly in the um, uh, crystallization toxicities. We don't want to give patients more medications than they can clear and have it kind of back up in their kidneys. Avoiding concomitant nephrotoxic drugs whenever we can. Keeping really good hydration. Generally, in the case of like high dose IV cyclovir, we're thinking 100 150 mLs an hour of like an isotonic crystalloid situation. And then making sure we're like monitoring patients really closely and we have early recognition. When that serum creatinine starts elevating quickly, acting quickly on the agent that we think is causing it is important. And then if AIN suspected, avoiding a rechallenge, because we know in that situation we may see a more quick onset in the repeat situation. Whereas, more of an ATN situation, maybe more dose related. So a rechallenge with a more appropriate dose may be a possibility in cases of ATN. Thank you for tuning in to this episode of Bite Size ID on our antibiotic toxicities. Please check out some of our other educational materials we have on our antimicrobial stewardship website. And I appreciate your attention. Thank you.